Ooh.
Okay. Hang on one sec.
Yeah.
Okay, ready?
I'm ready.
Okay, so we're broadcasting now.
Are we live?
We are. Yeah. So
Oh.
some of the participants come in. So welcome everybody to the webinar. Oh, this is filling up rather quickly.
Good.
We're leaving people at the edge of their seat waiting to let them in at the last minute stuff.
Oh yeah, I see a few people coming in. Very good.
Couple of familiar names here. Welcome everyone. If this is your first Zoom or Zoom webinar with us, feel free to start to familiarize yourself with the chat box. So you can say hey in there or anything you'd like really. So if this is your first time doing a webinar with us, why don't you comment in the chat box first time? Or if you've done our webinars with us before, why don't you comment in the chat box, veteran, webinar veteran.
Let's see.
First time. Oh, welcome guys.
Welcome. Oh, Erin, you're a veteran.
I've been here before. Hi, Samantha. Welcome to the webinar.
What's our time? Oh, we have a few more minutes. We'll let people roll in here.
Yeah, for sure. Welcome, Anne. We're looking forward to this evening. We have lots of good information for you guys coming up.
It's going to be great.
Is everyone starting to get out a little bit more with some of the restrictions being lifted? Has anyone hit up a patio or any restaurants or anything? Yes, Samantha, you're automatically muted. We'll talk about that in a little bit. But yep, because we're in webinar mode, you'll just be able to hear Steph and myself. So if you need to communicate with us, feel free to use the chat box to ask us any questions or comment or talk to anyone, really, any of the participants as well. Yeah, so what's that, Steph?
I was going to say, have you hit any patios yet?
Patios yet, planning to soon. Yes, no, I haven't yet, but I'm super stoked. I have a reservation tomorrow at the Keg patio in Newmarket. I'm like,
awesome.
First go big or go home. Had a gift card sitting in my wallet that I've been like waiting to use. And I'm like, do I do the takeout? But I feel like with the Keg, you can't do takeout. It's just not the same.
No, you need that fresh steak.
Not like hot fresh, for sure.
Yeah, for sure. I have not been yet. I'm anxious to get out there and be on a patio. Yeah, work my muscles, you know.
It's one of the best ones to work in the summer.
Yes. For reference, everyone, it's your brachialis. It is your drinking muscle. Flex it. Or water. I'm loving these bubblies. This is my summer drink for sure.
Oh, hi, Lynn. How are you? Oh, you're using Sydney's computer, but your name is coming up, right? So that's good. We've talked lots. You'll learn a little bit more tonight, hopefully.
Is our sound and everything okay for all the listeners out there? Thumbs up. Good. All right. Thanks, Lynn. All right, Erin, it's 7:30. You think we should get this rolling?
Oh, Matt had raised his hand. Matt, do you have a question or something? Can you type in the chat box to us if you do before we start, baby? Or I'm not sure if that was an accident.
Maybe it was an all good. Sounds good.
Hear you, hand raised. Right. Oh, an accident. Okay, cool. Okay, yeah. So why don't we get started? And if people roll in late, that's totally fine. So welcome to the webinar, everyone. So we are going to be debunking the shoulder tonight with you. The webinar should last about 45 minutes to an hour approximately, with questions and answers at the end. If anyone has to go early, no problem at all. The webinar will be recorded and posted to our website after. So feel free to check that out if you're not able to stay for the full thing.
All right. Uh-oh.
just in case it seems like we have a lot of people that it's their first time to our webinar series. So just a little intro here. Yes, you are muted. However, if you have to ask any questions, please feel free to use the chat box. Just make sure that it's changed to everyone or all panelists and attendees. Or if you want to message myself or Stephanie directly, you can just change that drop-down menu to one of the two of us. If you have an anonymous question, we also do have a Q&A feature, I believe, that's at the bottom there. So if you type something into that, then Steph and I will do our best to answer it throughout the presentation, or we'll potentially even answer it in the live Q&A at the end. I think that's all we want to cover there. Also in terms of, hi Gino, also in terms of protocol with the question and answer, we do ask that you guys kind of keep the questions more general. Like if you have independent concerns or concerns about your own personal shoulder or case, we're happy to talk to you about it, but either shoot us an email at the end of the presentation, our information will be there, or you can call the clinic and we're happy to talk with anyone before you make an appointment to come into the clinic, okay? So a little introduction. So I'll introduce myself first. My name is Erin. I did a Bachelor of Science in Human Kinetics from the University of Guelph and graduated in 2016. And then my Master's of Science in Physical Therapy from the University of Toronto in 2018. I'm a registered physiotherapist and I have been working at Aurora Sports Med ever since then.
Awesome. And I'm Stephanie. I did all three of my degrees at Western. The first, my kin degree, and graduated in 2013. And then I went back for physio and I graduated in 2015. I started working at Aurora Sports Med in 2017 as a physiotherapist. And then I went back to Western in 2018, 2019 to do an advanced physical therapy degree in manual therapy. And with that, I got the designation FCAMT, which is a fellow of the Canadian Academy of Manual Physical Therapy. So yeah, I've been working here for about 5 years and I will be shortly moving over to Bradford as we expand our clinics, and I will be clinical director over there. So you'll catch me there, but I will also be here for the remainder of the summer. So I'm not going just yet, but I'm really excited for our new adventure over there as well. All right. Trying to get these slides to work, Erin. Sometimes it's being a little bit sticky with me. There we go.
Okay, guys, so we're going to start with some questions. We really want to know who is joining us tonight. So these will be answered anonymously, but if you'd like to participate, please feel free. So the first poll should be coming up now.
Yep, I see it.
What's your age? So there's a few categories there.
Yep, we're all filling in there. Good.
About 60% accounted for. You guys are pretty quick tonight.
Yeah, very quick.
Impressed.
Let the last few votes come in.
Good. Give it a few more seconds in case anyone's casting their votes. Okay, perfect. Let's end it. So we'll take a look. So it looks like we have a small percent, 21 to 40, about half of our group in the 41 to 60 group, and over half in the 60 plus group.
A mature audience with us today. Established. Love it.
Super mature. Okay, perfect. We have a couple more questions for you guys. I just have to figure out how to do that. There we go. Okay, second question is, how long have you had shoulder pain? I'm just here to learn. I feel great. Less than 3 months, 3 to 6 months, 6 to 12 months, or greater than a year. I'm happy to see that there's people that feel great and they're just here to learn. That's so
yeah,
nice.
That's so good. Love seeing that.
Rehab. We're learning before injuries happen. That's good. Okay, perfect.
Good.
So, share those. So about 15% just here to learn, a couple less than 3 months, and then majority are kind of heading into the 3 to 6, 6 to 12, and even we see our majority here actually being shoulder pain persisting beyond a year. So you're not alone. There's lots of you out there that are dealing with this, and we're hopefully going to give you some more information about why this may be happening and what we can do to help it. Okay. My last question before we get going is, how did you injure your shoulder? Was it a sports injury, a fall, or some other type of trauma? overload, meaning, you know, just repetitive kind of use on the shoulder, or you have really no idea why this has happened to you. Perfect. You guys are quick. We're just about
A little bit of everything, it looks like.
minutes, actually.
Yeah.
Perfect.
Good. Yeah, kind of even across the board.
Well, even across the board, yeah. Overload, I have no idea. I'm just old. That's okay, guys. You're not old. We're going to help you work through it. This is good. Okay, perfect. So we'll come back later in the presentation.
Okay, there we go.
So today's agenda. So we're basically going to start by going over a pretty solid review of shoulder anatomy, what it looks like, and the mechanics of the shoulder, and how when those mechanics are optimal or dysfunction in the mechanics may lead to an injury. We're going to talk about common shoulder injuries and what all those big scary words mean. We're going to talk about your options for treatment. Do I need a surgery, or what are my other options? And we're going to talk about how to bulletproof your shoulders with some really key important exercises. And we'll finish off with a live question and answer period. And of course, a giveaway, which we're going to keep that a surprise. We'll probably do the giveaway before the Q&A, just so you guys have room for the presentation, and whoever wants to leave after that is totally fine.
Okay. Sorry, my thing keeps going back every slide, so this might be a long presentation if it keeps doing this. All right, we're gonna give it another go. Come on, there we go. So I'm gonna start talking to you about the shoulder anatomy. So when we talk about the shoulder, we're gonna talk about the shoulder girdle as a whole, and it is made up of 4 main bones. So we have the scapula, which is your shoulder blade. It sits on your thoracic cage, so on your rib cage on the back side of the body. And then we have the clavicle, also known as our collarbone, and it connects our shoulder blade to our axial skeleton. So it keeps our arm attached to the body. And then we have our humerus, that's our upper arm bone. And as you can see, it's a long bone and it has a spherical shaped head. And that's what sits onto the shoulder, or onto the shoulder blade, onto the scapula to create our shoulder joint. And then we have our sternum, which is not pictured here, but that's our chest bone, part of our rib cage. And like I said, that connects with the collarbone, the clavicle, to help keep your appendage, your arm, attached to our axial skeleton. So those are our main 4 bones that make up our shoulder girdle as a whole. And we'll talk a little bit more in hopefully the next slide if it goes forward for me. Oh, it did. Very good. So then within these 4 bones, we have 3 main joints. So the first is our glenohumeral joint. So gleno is the name of the glenoid fossa, which is part of our shoulder blade, our scapula. It's a socket joint. It's not very deep though, as you can see. It looks quite shallow. The analogy I like to use is that it's like a pasta plate versus your, cereal bowl that's much more deep. So it is a little bit flatter, but it does articulate with the head of the humerus, which is a spherical shape here. So that makes our shoulder joint the glenohumeral joint. Then we have our AC joint, our acromioclavicular joint, and that is made up of the clavicle and the acromion. So the acromion is a hook that comes off the back of our scapula, so it's part of our shoulder blade, and it connects with our clavicle there. It isn't as ball and socket joint like your glenohumeral joint. It's more planar, so it kind of moves like this, and it's connected with lots of ligaments here. We often hear of the AC joint when hockey players and people who fall on their shoulder have an AC joint separation. Then we talk about our sternoclavicular joint. So again, the sternum being our chest bone, and the clavicle articulate, and it's right here. You can feel these 2 bumps on your chest. So that's your sternoclavicular joint. And again, that is what connects our shoulder girdle to our body. But then we also want to talk about this scapular thoracic joint. And joint is in quotation marks here because it's not a true articulation like these bones here where there's ligaments and things holding it all together, but it's more just how your scapula, your shoulder blade, sits on your thoracic cage and it moves. And it's really important for movement, which Erin's going to talk to you about in our next slide. But that's the basic anatomy of the bones that make up our shoulder joint.
Just realized I'm on mute. Perfect. So there are 3 planes of movement that the shoulder joint is able to move in. So the first we'll talk about is flexion, which is lifting your arm straight in front of you, and the opposite being extension, where it reaches behind you. We have abduction or abduction, which is moving the arm to the side above the body, and adduction is bringing it back. So we talk about adding the limb back to the body is your adduction. And the shoulder is also capable of rotating inwards and rotating outwards. And we call that internal or medial rotation, and then to the outside, external or lateral rotation. And so in particular, when it comes to overhead movements, which I think is a really common complaint, a lot of the times we need good contribution from that scapula that Steph was talking about, where the scapula has to move along the ribs. So it's not just about having good movement happen in that ball and socket joint. It's about all of these joints functioning together to allow us to have optimal movement. Okay, so that's a really important piece to consider when it comes to the types of treatments that we do for the shoulder. Okay.
Oh, sorry.
Okay, so let's talk about that ball and socket joint again. So that shoulder joint is really like a golf ball sitting on a tee. So that glenoid fossa that Steph mentioned is super shallow, and we have that big sort of head of the humerus that sits on that shallow surface. And so as a result of this, the shoulder is really built for great mobility. So we have tons of movement in the shoulder joint. But as a result of this, it does compromise stability. So the next slide, we're going to talk about where this stability comes from in the shoulder. So there's a lot to unpack here, so bear with me. So we talked about shoulder, great for mobility, not so good for stability. So how does the shoulder joint acquire that stability that we need? So the first is through what's called our glenoid labrum. So Steph, do you mind just kind of outlining the labrum there? So this is essentially a piece of connective tissue that acts like a suction cup, and it sits on that fossa of the scapula or the shoulder blade, and it basically helps to deepen the socket so that that head can sit a little bit more comfortably as opposed to being a golf ball that's fallen all around the tee. The second main contributing factor that helps to stabilize the shoulder is our rotator cuff. So buzzword, we have all heard that from our doctors or our friends or this and that. Oh, my rotator cuff or my rotary cuff or whatever you want to call it. We've heard every name in the book. But the thing to keep in mind about this rotator cuff is that it is a group of muscles. It's a group of 4 muscles that basically hug that ball and socket joint. So we have 3 that sit on the back of the shoulder, which is where Steph is pointing to now. We have the supraspinatus, the infraspinatus, and the teres minor. And on the front of the shoulder and shoulder blade, we have the subscapularis. So together, these 4 muscles have a couple jobs. So the first, and where they get their name from, is that they're really important for that rotation of the shoulder that we talked about. And that's why it's called the rotator cuff. But even more importantly, we have to have a good balance in these muscles to keep that golf ball centered on the tee. If we don't have good function in these muscles, that golf ball can slip upward, it can slip forwards. And so we have to have a really strong muscular system to provide that stability for the shoulder, since its basic anatomy is not really built for that stability. And then the last piece here to think about is all the other muscles other than the rotator cuff that are so important for the movement of the shoulder. As you can see, we've outlined a bunch here that make up the back, the neck, and these all attach onto the shoulder blade. And if you'll remember, I mentioned how when we talk a lot about those overhead movements, it's not just that ball and socket joint that we need to be working for us. It's that shoulder blade also moving along the rib cage. So we need these muscles to be strong. We need them to work efficiently and effectively to be able to get into those overhead positions in a functional way without causing injury. Pull time. Also, so Rick, he's having difficulty seeing the slides. I asked that he log in and log out, still can't see the slides. I am not an IT person in the slightest. If anyone has suggestions for Rick, please feel free to put them forward. I'm not sure if you're on a phone or computer, Rick, but I'm not sure if that makes a difference. But again, please feel free to listen, and the slides and everything will be posted to our website. So if you can't see it tonight, you will be able to see it when we post it there in the next week or two, okay? All right, let me bring that next poll up. So after we've gone through all that anatomy, are you confused yet? Oh, an A+.
A pluses. People are getting it.
What are these girls even talking about?
Yeah. We're getting lots of those votes too.
Perfect. So casted about 75% of the votes there. Let's take what people are saying.
We're explaining it okay.
With us. If you're confused, guys, again, we're happy to answer questions and go through this at the end, or again, if you want to talk personally, we're more than happy to go through it. This isn't easy stuff. The shoulder joint is incredibly complicated, and we're really just touching the surface here. So bear with us. If you don't understand, it's okay. It takes time and repetition to really understand how these things function.
For sure. All right, let's see if I can get this slide to move in the right direction. Nope. It's just the internet, I swear.
Okay, it's not you, don't worry. Okay, so now we're gonna get into some common shoulder injuries. So the first thing we're gonna talk about is a rotator cuff tendinopathy. So a couple points I wanna talk about here is firstly, remembering that rotator cuff is that group of 4 muscles that we talked about. And also remembering that the tendon is the white connective tissue that you see here that attaches that big juicy red muscle into the bone. So the rotator cuff tendinopathy is happening in any of the tendons of those 4 muscles, okay? So what does this mean? So what is opathy versus itis? So a lot of us have heard the term tendinitis. So anytime you hear itis, this means inflammation. So if it's a tendinitis, that means inflammation of the tendon. If it's a bursitis, that's inflammation of the bursa. So this really applies to a lot of medical terms. When we talk about an osis or opathy, in the case of tendinopathy, this is more indicating an overuse condition. And so it's not like I just fell onto my shoulder and it's really inflamed and irritated. This is something that accumulates over time, over months and years. And when you look at the cells under a microscope, we actually see that there's no inflammation in these cells, okay? So the thing to keep in mind with these is often what will happen is we have an injury starting to accumulate and we have some inflammation. So the body sends in these healing cells, but over time we continue to irritate and we continue to do that repetitive motion without really knowing. And over time, the body says, well, I'm not throwing any more inflammation at this. This sucker is as good as healed. I've thrown swelling at it for 3 months. And so it kind of thinks like, this is your new normal. So it stops that process of trying to heal that injury. And what we're left over with is this kind of tendinopathy or overuse condition that is no longer inflammatory. Okay, so in the clinic, the most common complaints are going to be of that shoulder pain that comes down the outside of the arm. In particular, pain with rotating outwards. So things like putting your jacket on, or even reaching behind to put a bra on, or any lifting or overhead motions. And we'll also experience pain with sleeping or night pain on the shoulder commonly. Before we go to the next slide, Steph, sorry, I just want to, that's okay, that this picture is showing shoulder impingement. So we have to remember that there's a lot of structures in this tight space in the shoulder. Steph went over all those bones that are in there. We talked about some of the muscles and other connective tissue. So we have to remember that posture plays a really big role, because when our shoulder's not in an optimal position and we're rounded, we're typing, we're driving, we're sitting at a desk, we're living in front of us. And so we tend to round the shoulder forward more often than not. And what can happen is over time, these tendons can go through compressive force from some of those bones and other structures. And ultimately that is what ends up leading to some of these injuries, is that compression and irritation over time, okay? So, again, coming back to that point, people that are at higher risk for developing this are these awkward or static postures, heavy work, repetitive arm movements, or that are especially overhead. and a lack of rest. So this can be both occupational, like sitting at a desk for your whole day, or maybe you're a carpenter that's up overhead banging or something like that. But it can come from, or it can come from a sports injury, you know, a tennis player that has been doing that overhead. Ultimately, the treatment is we have to address the factors that are leading to that injury in the first place. So like I mentioned, you really have to look at posture. What's the position of your shoulder? Are you causing strain on those tendons? Are you causing strain on those structures? And we work on strengthening that entire shoulder girdle. So coming back to all those muscles that sit around the shoulder blade that help optimize the position it's in, that help us with overhead movement. And then we also work on that rotator cuff strengthening to recenter that golf ball on the tee, get you in an optimal position and get things strong and functioning a bit better. The last thing is isometrics will sometimes work for a tendinopathy, which is where we're working on activating muscles without actually moving the arm. So for example, if I apply pressure, but I'm not actually letting my arm move, that would be an example of an isometric.
Oh no. Sorry.
What happened?
I don't know what's going on with this thing. Okay, sorry about that. Recenter ourselves here. Okay. On the spectrum of tendinopathy is rotator cuff tears. So there's full thickness tears and partial thickness tears. Not all tendinopathies will progress to a tear, but it is possible for some of those tendinopathies that continue to get worse and they're not treated. So bear in mind, all the things that Erin said will help your tendinopathy, but there are the rare occasions where it can progress to either a partial thickness tear, this one here, or a full thickness tear where you can see that the tendon has actually separated apart. So we'll talk a little bit more in our next slide. So these tendon tears, full or partial, can be traumatic, such as a fall on an outstretched arm, or you fall on a ladder and you pull yourself down like that. Or they can be what we call degenerative, so happening over time, or an atraumatic tear, so non-traumatic. Generally, with our degenerative and atraumatic tears, we see this with increasing age. So we know we have a mature audience today, so there may be a few of you who have degenerative atraumatic tears. And as Erin mentioned with our tendinopathy, it is often associated with that overuse. So if you're a carpenter, an electrician who's working overhead, you're the tennis player, a volleyball player who's really, cranking on that shoulder with the overhead movement a lot. If you combine that with age and the natural changes that happen in our tendons, like sometimes decreased blood flow, and as we age, our cells do tend to die out. That's why we do get wrinkles and gray hair. Things are changing in our body. Your tendons are also getting wrinkles and gray hair. They're not as, spry as they used to be when you're an 18-year-old. They do change with time. So when you combine repetitive overuse over many years, we can see these degenerative atraumatic tears. So there is an increase of percentage of people as they age. We see that number go up and up, especially with those atraumatic tears. What's interesting to note is that about 25 to 50% of people ages 60 to 80 have atraumatic but non-symptomatic, so non-painful tears when you look at people's MRIs or ultrasounds. So most of you are probably walking around not even knowing that, maybe your non-painful shoulder also could have a tear. If you go and ultrasound your neighbors, they probably have a tear. It's very common. So not all tears are painful. The tears can also occur in one or multiple of the rotator cuff tendons. So oftentimes we will see that it happens with our supraspinatus tendon, because if you think back to those anatomy slides, that's the one that comes underneath that acromion and has to sit underneath the hook and attach onto the front of the shoulder. So that is our most common, and it does have the least amount of blood flow as we age. So it is the most common tear, but you can have it in multiple, especially if it is a traumatic, so one of those falling type injuries, you might have multiple tears across the different tendons. So the people that we see often are our mature audience, so our 60 plus. Often you'll see that people come in with night pain. As Erin mentioned, that overhead movement, we call it a painful arc of abduction. So it's quite painful through this range of motion, especially if it's that supraspinatus tendon, because that's the one that is most involved in that movement. And we'll also notice that you're not only painful with your external rotation, as Erin mentioned, but you're actually weaker in that muscle. And that tells us that it's more likely a tear than just a tendinopathy when there is a weakness associated, especially with a full thickness tear. Oftentimes you won't be able to lift your arm or rotate out to the side due to the weakness and the tearing of that muscle. As Erin mentioned, our treatment is very similar to our tendinopathy. We are going to address our scapular, so our shoulder blade movement, and our humeral head positioning, so trying to center that ball in the socket, keeping that golf ball on the tee. We're going to work on posture. And then you do want to strengthen the rotator cuff in various positions and stages of movement. So you want to start in a least traumatic, least aggravating position. So arm at your side, you might do some rotator cuff strengthening down here. And as pain subsides and you can get to better movements, we might start into rotating up higher and making it more functional, working on throwing mechanics and trying to get you back to the things that you like. So stay tuned. We have a little bit more information on treatment for tears and other options, but the big thing here is strengthening.
Okay, so moving on to number 3. So we're over halfway there, guys. So the third one we're going to talk about is subluxation or dislocation and the hypermobile shoulder. So keeping in mind that a shoulder separation is very different from a shoulder dislocation. So a shoulder separation is going to happen at our acromioclavicular joint that Steph talked about earlier. So where our clavicle or our collarbone attaches to our scapula. That's going to be a separation of those bones through the ligaments. A dislocation or a subluxation is where we have that ball and socket joint, the golf ball on the tee, that we have pop out. Okay, so that's the difference between separation and dislocation. So let's go ahead there, Steph, to the next slide. So if we talk about the hypermobile shoulder, so mobility in any joint is kind of on a scale. Hypo meaning that joint is really stiff and really difficult to move, and hyper meaning we have actually a little bit of excessive mobility in that shoulder. So Steph and I were joking the other day about when you're at a party and someone's like, hey, watch me pop my shoulder out. And it's like that kind of cool party trick, but like they're really just like dislocating their shoulder. It's actually kind of gross. But basically a subluxation is where the ball pops out of the socket and will quickly reduce and pop back in. And a dislocation is where it pops out and stays out, and then you have to kind of get it reduced back in. So this is typically almost always a traumatic injury, keeping in mind that the ball can pop out in multiple directions, but it's most common that it pops out the front. And the other thing to keep in mind is that one thing we didn't mention about the anatomy is that ball and socket joint, that shoulder joint in general, is basically in a thick connective tissue capsule. So if you picture taking that shoulder joint and wrapping it in saran wrap it all around this really tight connective tissue. And this is one of the things that also helps to stabilize the shoulder. Once we have one injury where that ball and socket joint pops out, we've now stretched that capsule that keeps us nice and snug. And that actually increases your risk of a second dislocation. So I believe the risk is higher, less than 20 years old. But if you're a little bit older, I believe above the age of 40, not as common to redislocate. But remember that this is often happening from a traumatic injury, that these things don't happen in isolation. You may also have a rotator cuff tear or a ligament tear or something like that happen in the shoulder as we get a little bit older. Treatment is really focused on just strengthen. Of course, if you dislocate, once it's reduced, you'll often be put in a sling for a little bit. But then again, it's just about getting all of those muscles, that rotator cuff, the shoulder blade muscles that keep the shoulder snug and stabilized, like we talked about, getting them really, really strong since that stability has been compromised with an injury like this.
All right, I get the pleasure of talking to you about adhesive capsulitis, or also known as the dreaded frozen shoulder. So as Erin mentioned about that capsule, we have this thickening of ligaments that goes around our humeral head, around the glenohumeral joint. Generally in a healthy population, it is more pliable, more movable, like our saran wrap. But in frozen shoulder, it becomes very inflamed and it thickens. And instead of it being a nice, pliable, movable structure, it ends up being more like duct tape. So it's not going to move as well as our saran wrap that can stretch and move and allow for all of our beautiful movements of the shoulder. Instead, it's quite stiff. So I'm going to talk to you more about that, but you can see nice, healthy shoulder, really angry shoulder. So frozen shoulder contraction syndrome is the new name in the literature, just in case they wanted to confuse you more. But what happens with frozen shoulder is we get what we call adhesions and fibrosis. So as I mentioned, it's taking those ligaments in that capsule, which is nice and movable, and it's making it much more thicker. It turns more leather-like or duct tape. It's not moving very nicely. Then there's lots and lots of inflammation in the joint capsule as well. Now, why does this happen? That's a great question. The literature is very conflicted in why it happens, but our two main thoughts are that it is idiopathic, meaning happens just because, which is a really crummy answer that we have to give you as therapists. It's not great, but sometimes it just happens. Then we have secondary to trauma or surgery. So we will see people who go in for a shoulder surgery, such as a rotator cuff surgery, decompression surgeries, going in after having a dislocation, and they are progressing well after surgery, and then all of a sudden develop frozen shoulder, and their progress stops and they get much stiffer. Also, it can happen secondary to trauma. So you can have a rotator cuff tear, a fracture, and you may just develop this secondary frozen shoulder. There are some noted risk factors. Some people who are more likely to develop frozen shoulder. We see it more in females. I believe it is 3 to 2 in the ratio there. So women tend to get it a little bit more often. Again, it is our middle-aged group of women and men. If you have a history of diabetes, type 1 especially, but also type 2 diabetes can lead to an increased incidence of frozen shoulder. If you have autoimmune, we typically see this with people who have thyroid conditions, but any kind of autoimmune spectrum disorder does increase the likelihood. If you have a family history, so if your mom, your sister, your aunt had frozen shoulder, there's a good chance that you could also develop it. And then the worst thing that I have to tell people is that if your other arm was affected, unfortunately, you have a greater risk of your second arm going. So if you have any of these factors, just let us know. When we talk about frozen shoulder, it is described in 3 main stages. This is the characteristic of frozen shoulder. This is what we see in the literature. This is what physios know and how to diagnose a frozen shoulder, because the initial stage, freezing, is a very tricky stage to distinguish frozen shoulder from some of our other pathologies we talked about, our tendinopathy or our rotator cuff tears. So freezing stage is just a lot of pain. It's usually quite aggressive pain, usually affects your sleep. Pain in most movements, very much so at the end range, elevation, rotations, all of our combined movements. But pain is the predominant factor in our freezing stage. So as I said, it is quite tricky to differentiate why you're having pain. Is it a tendinopathy? Is it a rotator cuff tear? Is it bursitis? It's quite tricky to differentiate in the beginning. But then when we get to frozen stage, or stage 2, that's when we can really tell you that it's frozen shoulder or adhesive capsulitis. This is when our shoulder gets really, really stiff. The pain might subside a bit. It's usually present in the beginning of stage 2, but you get stiffness, and our telltale sign is lack of rotation at 0 degrees. So you can't go much further than this. Our normal rotation is right out to the side, but most people get stuck with about 5 to 10 degrees of rotation. We also see quite a limitation in our abduction and flexion. Most people are not going much higher than 90 degrees. It does stiffen quite abruptly, and it will continue to stiffen for quite some time until we get into our thawing stage, where it just starts to recover kind of on its own, and we'll start seeing improving range of motion and much less pain. So that's our favorite stage. That's when we can get you moving for sure. So recovery, what is our treatment for this? It is time. Frozen shoulder can last several months to a couple years. 3 years has been reported, but most often we're looking at about a year as you move through these stages of pain, stiffness, and then thawing and regaining your motion and regaining your strength. In the beginning, we do want to talk about cortisone injections, pain management. And if that is administered soon at the beginning of your stage 1, it can help with your prognosis over the course of that several months. So it might help you move through the stages quicker. Also, physio is obviously indicated as well to try to help you maintain your mobility and your strength through that process. All right. Another poll.
And this is our last poll of the night. So have you been diagnosed with one or more of these conditions by a healthcare professional, or maybe by Dr. Google? Yes, no, or I am still lost. I'm so happy to see that I'm still lost with 0%.
So far.
Makes me feel really good. Perfect. So some numbers still coming in. We'll give it a few more seconds.
Sure, yeah.
Okay. So yeah, so 70% have heard these terms before and 30% no. We have heard that, we know from the beginning there's a few people that are just here to learn. So, but yeah, 70. These are really common, guys. Really common.
Awesome. Okay. See if I can get this slide to work here. Oh, no. There we go. So after we talked about all of that pathology, we asked the question, do I need an MRI? That is a question Erin and I and all the clinicians get often here. And the answer is, it depends. Physiotherapists, we are very skilled with our physical exams and our assessments, and we can use our clinical reasoning to determine the source of pain without needing further imaging. We have tons of tests, our strength tests to determine potentially which muscle is affected. So we talked about those 4 rotator cuff muscles. There are special tests to help us figure out which one of those muscles is affected. We can also work on repositioning your shoulder. If you've ever been in the clinic with us, sometimes we'll, push that humeral head, that ball back into the socket and get you to do your motion again. Does that change your symptoms? We open up your chest a little bit and tip your shoulder blade back and get you to go through those motions. Does that change your symptoms? So we can modify your shoulder position to see which muscles might be affected. And sometimes we don't need any further imaging, because we're so good at diagnosing. But sometimes we do need imaging. So when there is a traumatic event, X-ray and ultrasound might be the first line of imaging that we can use to see if there are any changes in the bones or the tendons. Oftentimes, if you dislocate, you will want to get an X-ray. So I hope most of you can see that this is not a normal shoulder. Unfortunately, this person has had an anterior dislocation. You can see that the ball is sitting in front of the socket. So an X-ray would look to see the position, but also to see, is there any damage to the bone? Because sometimes when these joints come out of the socket, if they hit hard enough, we can see little fractures on the humeral head or on the glenoid fossa. And that would be something that a surgeon would want to look at to determine, does this person need to have surgery? Does this person need any plates or pins? Does this person just need to be in a sling for a little bit longer than our traditional dislocation who doesn't have any fractures? Then doctors may order ultrasounds. So to some of you, this may just look like a bunch of squiggly lines. But for the trained eye, and I'm not the trained eye, trust me, this is showing us that there is a tear in our supraspinatus tendon. So you can tell that there's a black spot there. It doesn't look the same as you go across. So ultrasounds are one of the first lines of treatment to look at the more superficial structures of the shoulder. And again, that might help a surgeon determine if they want to do any sort of surgical interventions. And then we do reserve the MRI for assessing some of our deeper structures, or again, for the surgical consults. Sometimes surgeons want to know how big the tear is, how deep the tear is. Is it, pulled away quite a bit? Is there a big gap in between? So if they are going in for a surgery, so oftentimes in those traumatic cases where you might have had a big fall and something did really resect back, they might want to get an MRI to see how much damage there is. And assessing those deeper structures. Erin mentioned the labrum at the beginning of our slide. We didn't talk about it in pathology section, but your labrum in here can be damaged. And unfortunately, even an MRI might not show that. Sometimes you have to inject dye into the shoulder with your MRI to get a better picture of what's going on in there. And again, that's often used for surgical consults. So do you need surgery? That's a good question too. Most of our tendinopathies, our partial thickness tears, our aging, atraumatic, degenerative tears can successfully rehab without the need for surgery. There are some great stats out there that show about 75% of people at 2 years are equal to the people who have gone for surgery in terms of their rehab goals. So most people can rehab successfully without needing surgery, especially in our atraumatic, degenerative, kind of aging shoulders. In some cases, when that conservative management does fail, surgery is required. And as I mentioned, those bigger tears where it's more of a traumatic full thickness tear, they might go on to surgery. Some of our younger athletes with dislocations may also go on to surgery because, as Erin mentioned, there is a higher dislocation recurrence rate in our younger population, and anyone who has any bone damage. So if we dislocate and the bone is damaged, those would often go on to surgery as well. But you don't always need surgery. We did talk about the cortisone injection. Those can sometimes help in the earlier stages of our tendon injuries or in our adhesive capsulitis, because it will minimize the pain and allow you to get greater range of motion. We do have 3 doctors on our staff here, Dr. Wangshu, Dr. Nanos, and Dr. Tam, who can speak more to our different types of injections, but most of them do cortisone, which can help with that pain as well. So what do you need? Physio. Of course you need physio. That's why you're here. So when we talk about physio, that includes manual therapy and exercise. So as Erin and I mentioned before, we're going to talk a lot about shoulder blade mechanics. Something that we can assist you with is placing your shoulder and the ball and socket joint in a specific position and actually getting you to work on the movements. We call this mobilization with movement, where the therapist will mobilize the shoulder and you will move through it, training your brain how to activate those muscles in the correct fashion with a little assistance from our hands. Oftentimes, if you have a stiff shoulder, like our frozen shoulder, you'll need someone like us to crank on that a little bit. I apologize to any of our frozen shoulder patients in the audience. You know how it feels, but it is very helpful, and you can see that your shoulder mobility does get better. And then we want to train your movements with exercise. So we use different types of equipment for this. We can use just active range of motion, bands, kettlebells, dumbbells, body weight. But we want to make sure that your shoulders are strong and stable and moving concentrically, all perfectly together, synergistically. And that's where we talk about that rotator cuff and scapular humeral rhythm, everything moving nicely together. So we are going to demonstrate some exercises. Erin is going to be our lovely demo, and I will be talking over her.
The exercise stuff, I just wanted to add on to like everything that you've been saying. I think when it comes to these shoulders, as you guys know, like we saw the majority of you have been dealing with this pain for over a year. And I think you do need an element of patience with these injuries, like for that these take a long time to accumulate under the surface, and there isn't really a quick fix for a lot of them. So just be patient, be diligent with the exercises that you're given. It really takes time to have these changes occur. And I get how frustrating it is. And we see it in here every day, but just be patient and keep working hard, and it will pay off in the long run. Yeah.
Sure. Thank you. That's great.
See me, Steph, maybe just relay to me if you're seeing in the chat. And
okay.
I can adjust my computer.
Okay. Trying to pull up the little chat thing. Can't see it. Let's see. Okay. All right. So the first one we're going to talk about is scapular push-ups. So this is to warm up our shoulder blades as they move around our thoracic cage. So Erin's on her hands and knees, and she's allowing her chest to sink through and push away. So she lets her chest sink through, and then at the top of the push-up, she kind of rounds the shoulders forward. So this is a great warm-up to get those shoulder blade muscles that are going to allow your shoulders to upwardly rotate and come around your thoracic cage, because we do need that for overhead movements. So your elbows are locked out. That's the biggest key here. We don't want you to going into like a push-up position, and it's literally just your chest kind of moving up and down around those shoulder blades. Awesome, Erin, thank you. Then we're going to go into our prone angels, since you're on the ground there. So this is a good one for those of you who do have the overhead mobility. Erin's going to start on her stomach. She is starting with her hands on her bum. The palms are facing the ceiling, and then she rotates her arms overhead and brings them back down. She's squeezing her shoulder blades the whole time. It's not about how high her arms can go, but just the movement of those shoulder blades as she's on the ground, squeezing them, getting into those overhead positions. Now, we know that this is not appropriate for all of you here today, but for those who do have good mobility, this is a great warm-up or activation exercise. Then we'll get up into standing. It's an alternative for some of the people who cannot get onto the ground or don't want to get onto the ground. We're doing bent over Y's and T's.
Hang on 1 second, Steph. Eva, where do you need me to move so that you can see properly? Can everyone else see that okay? These two floor exercises.
Good.
Move on, and then if anyone else, just let us know. It's good.
Everyone else is good. Okay. All right. Sorry. Yeah, very clear. All right. Good job, Erin. So Erin's going to stand up for us now. Maybe just tip your screen down there. Thank you. So she's going to bend over, hinging at the hips, and she's going to start doing a Y position. So she starts with her hands in front of her, and then she brings them up like she's doing the YMCA, and she's leading with her thumbs to come up into that Y position. Her back is flat, her head is down, and she's not allowing her shoulder blades to come up to her ears. Great job. She's going to switch into the T. So the T is where she brings her arms more out to the side, and she's squeezing those muscles in between her shoulder blades, bringing those arms back and working on her middle traps. Again, these are all activation exercises for your shoulder blades to make sure that when we do overhead work, the muscles that stabilize our shoulder and hold them back are active. So this is another alternative. Oh, we have another person who can't see Erin. I don't know what's going on. We have a few that can and a few that can't.
Is it that my video is not on, or that can you guys not see my video, or just not see me in the video? Because just make sure you're set to like your speaker view, that you can see. Is it possible there's a setting to see both of us at the same?
Yeah, there should be like a gallery view. If you only have it set to speaker view, then you're only going to see my face talking.
Yeah, so go to the top right corner of the page. If you can't see me, there's speaker view. And
I think like a little gallery where it's like two little dots.
You want to be on gallery view, guys, and that way you'll be able to see both mine and Steph's video. Yeah. Oh, if you're on a phone, you can only see one speaker. Okay, that's true. So let me pin my video.
Perfect. Good idea.
Okay, guys, I'm gonna pin my video. Let me know if that's better. Hanny, can you see me now? Okay, let's try there. Let's try with the video pinned. And Steph, keep an eye on the chat just in case.
Yep, I'm looking.
I don't know the inner spotlight that I have to do, but I'll pin it and hopefully that works.
Yeah, I think it says you're pinned now. Okay, so Erin's gonna show us a doorway stretch. So the last two exercises talked about strengthening the back. Can you move it a little closer to you, Erin? There you go. The last two exercises talked about strengthening the muscles on our back, but we also want to give our shoulder blades some space. Oh, Gino's lost you now, Erin.
I can
Okay,
only
Erin, do you want to talk through the exercises? Go ahead.
take 1 second. Let me try to now Erin is not there. Only 70-ish. Man, I'm not good.
Our webinar.
Are you able to change? Oh, here, unpin. Let me try to spotlight video.
There you go.
Okay, let's try this. Sorry, guys.
I'm like nervous to talk now.
Let's try that.
Okay, that seems to be working. We're good. Thumbs up. Okay. Okay, woo, good, we got it. All right, so Erin's gonna do a pec stretch. This is a nice one for people who maybe can't get overhead. So she's gonna place both of her hands on either side of the door, palms facing the wall, and she's just gonna take a step forward with her feet, not overly arching her back, but just getting a nice stretch across her chest. Again, you're just gonna hold this for about 30 seconds or so, and then you can take a break. This is a nice one, guys, that you can do whenever and wherever, because everyone has a door, I'm pretty sure. Somewhere in your home, you can go through a door and do this nice stretch. Great for at the office if you're back in the office. So this is kind of a no excuses stretch. I also have a video posted on YouTube, and I believe it was sent out with our webinar link before, showing all of those as well, where you can see me do those in my home gym. All right, we'll go to our next set of exercises.
I was gonna say, actually, that was a good slide to have the video issue on, because Steph does go through these all in the YouTube video. But now I think we figured out the spotlight seems to be working. So at least the next exercises, you guys will be able to see a bit better.
Yeah. Okay, so Erin's gonna set herself up to show us some strengthening exercises. So in our last set, we were doing activation just against, can you tip that up a bit, Erin? Thank you.
Running around here like a crazy person. Oh.
I hope no one gets motion sickness here. Okay, so Erin's gonna start with a banded row. This can be done with cables or with TheraBand. We have lots of TheraBand in the clinic, not currently because it's on back order, but we do have TheraBand in the clinic coming. Erin's gonna start with her arms locked out straight, and then she's going to bend at her elbows, squeezing her shoulder blades, pulling her arms back by her side like she's rowing a boat. What she's not doing is letting her shoulders creep up towards her ears and use all of her upper traps instead. Yeah, thank you, Erin, for demonstrating not a great row, but she's doing a great row there where she's pulling her arms back and squeezing her shoulder blades, activating those muscles in between the shoulder blades. Erin's gonna move to the ground. She's doing a great job here, transitioning. Thank you, Erin. And she's gonna show us a band pull apart. So this is a nice one to do lying on the ground because it takes your neck out of it, it takes your chest out of it, and you can just focus on your shoulder blades. So she's taking the band, her arms are starting straight above her chest, arms locked out nice and straight, and she's pulling the band down towards the ground as she squeezes her shoulder blades together. She's again not letting her shoulders creep up towards her ears. She's just focusing on those muscles in between the shoulder blades. And this is one that you can use with a thicker band because you are quite strong in these muscles. Great job, Erin. Thank you very much.
Thank you.
Then we're gonna get into our rotator cuff strengthening. As we mentioned before, our rotator cuff does rotation. So Erin's gonna show you with a band. She's gonna make sure first that her shoulder is in a good position, because the rotator cuff strengthening is only good if you're gonna have a good starting position. So Erin's thinking about drawing the ball into the socket very gently. It's different than squeezing your shoulder blades really, really tight together. It's just a gentle kind of tipping the shoulder back, drawing the ball into the socket, and then she's keeping her elbows at her side as she pulls the band apart. And she's just holding at the end. This one is going to really work on the compression of keeping the ball in the socket. The rotator cuff muscles are compressing that ball in the socket. This is a really important one for what we call motor control, retraining your brain on how to hold that ball in the socket. So it is one that you want to do with high repetition and a low load. So we're talking 15, 20 reps several times a day. All right, now we're gonna get into some fun ones. We're gonna make Erin sweat.
I was sweating like 3 slides ago.
Oh, I'm sorry. So then we want to talk about functional training. And this is different for everyone here. We have, probably some superstar athletes and some average Joes. And, me and Erin both fall into those 2 categories as well. So we want to talk about a loaded carry. So this can be done with dumbbells. It can be done with kettlebells. It can be done with a duffel bag. It can be done with groceries. With this, we're thinking about keeping our collarbones open, our shoulders just down and back a little bit, hands off to the side, not slouching, and carrying your heavy weights. Most people carry their groceries from the car. This can become a functional exercise for you. You don't have to do 2 at once. You can do what we call asymmetrical. If you're like me, you carry 16 grocery bags in one side and a Starbucks coffee in the other. So you can do one hand at a time as well if you only have one weight. So that's great for anyone who has difficulty getting overhead, because it's still a very good functional strengthening exercise. But if you do have the overhead mobility and you can get into overhead training, Erin's going to demonstrate an overhead press. So she's keeping her arm by her ear. Thank you, Erin. Her biceps by her ear. She's allowing the weight to go straight through her arm, right down the shoulder, down into the shoulder joint. She's not having her arm in front of her face or way behind, because we want the line of gravity to go right down. And then she's going to keep her core engaged, and she's just going to go for a nice walk forward and back. This can be done with dumbbells or kettlebells as well. But again, we do lift things over our heads all the time. So this is something that is quite functional, especially for our overhead workers. So there are many, many other exercises that we could show you, but you'd probably be here for 3 days, to be honest. There is quite a lot, and everything is specific to each person. These are just some of our few favorites that we enjoy giving to our patients. And again, everything's different based on your specific situation. So Erin and I are happy to talk to each and every one of you about your specific needs, and you can always come and see us in the clinic or send us an email if you have any questions about those exercises or exercises that you've been given in the past. Thanks.
That's funny. Away from the kids.
Yeah, sure. All right. So thank you guys for listening to us ramble about anatomy and pathology. And like Erin and I said, we're just touching on the shoulder. There are many things that we could talk to you about the shoulder. It is quite a complicated joint. And like I said, many, many, many exercises that we could tell you about. But thank you for listening to some of our most common exercises and pathologies we see in the clinic.
I just want to address Gino. Will you be sharing a list of those exercises? So here's what we'll do right now, guys. If you want a list of those exercises, please write in the chat exercises. We're going to save the chat, and we will send you an email with the attached, a sheet of the exercises that we just went through. So again, exercises, write that in the chat if you want. Also, if you want us to call or email you after the webinar, please write call or email, whichever your preference. If you want all 3, just write all 3 down. One of us will get in touch with you, okay? Awesome. So
everyone wants exercises. Loving this.
I'm already seeing Mike for some of those issues. Awesome. Exercises. Good. Very good.
Good. Awesome.
Okay, so
do you need to stop sharing?
Oh yeah, Steph, why don't you stop share? So guys, we're gonna go ahead and do the giveaway. So Steph, do you want to drum roll what the big giveaway is?
We are giving away a strength band and a lacrosse ball for all of your strengthening needs. So that red band that Erin was using, we will give you a fresh one, don't worry, in a package, which is great for doing rows, doing strengthening exercises, the band pull-aparts. I love it. I have probably several of them in my house. They are awesome. And then our cross ball, which will help you with any tightness in those muscles at the back, which we didn't address today, but it's another great one that we like to give.
Steph, are we doing like 2 separate draws, like one for the band, one for the ball, or is it like a winner take all?
It's a winner take all. It's a one time.
Okay, perfect. So everyone's name should be in here, guys. So let's go ahead. I hope you're like giving a drum roll at home. I'll like do my own drum roll here. Marilyn R. So Marilyn, please comment in the chat if you are here so we know that you can claim your prize. Where is my chat? I've lost it. Steph, can you see the chat right now?
I do, but I don't see Marilyn in terms of being here. Let's see if she's here.
Give her a cup.
I'll check the participants if she's here. If not, no, we don't have a Marilyn here.
All right.
Oh, round 2.
I love the sound that it makes. It just like gets me excited. My life is so boring. Anne, I saw Anne on here.
Yes, Anne is here.
And just comment in the chat for us just to make sure we know you're around. I know I saw that lady in here.
I think so. I am here. She's here.
Perfect.
Very good.
We'll leave it in the office for you. Ann P. Sorry, Ann Klein. Ann P was the winner. So Ann P, we will leave it at the office for you, and feel free to come by and pick it up anytime.
Awesome.
Okay. So I think we're moving on to the Q&A. So Ann P. The chat.
Oh, sorry. Yay. All right, Q&A. Do you want to take over the questions there, Erin?
Sure. So I'll read a couple to you, Steph, if you'd like to start. What does rotary cuff insufficiency mean, and what can you do about it?
Good question. So rotator cuff insufficiency talks to that issue I was talking about with the vascularity and how your tendons are not as strong as they used to be. That's my understanding of the insufficiency. There are many different ways to describe rotator cuff tendinopathy, tears, but that's usually telling us that your tendon is a bit degenerative and you are lacking some of that, the good healthy cells in there, and it's kind of fraying. That's my understanding. Don't quote me on that, but I believe it's more of like that tendinopathy. Does that sound about right to you, Erin?
Yep. Sounds good. Next question, should push-ups be avoided for any shoulder issues?
I would say no. There are proper ways to do a push-up, and I believe this is specific to each person, really. So you would want someone to assess how you're doing your push-ups. You don't always have to go full depth. We can work at different ranges of motion. You can start on a wall, you can start on a chair from your knees. There are many ways to do a push-up. However, we want to make sure, as we talked about through this whole presentation, about that ball and socket joint staying in the joint. It is quite common that when people come forward, they really dump through at the end of their push-up. So we want to make sure that that ball is staying in the joint and you're actually really squeezing your shoulder blades the whole time through a push-up.
Yeah, I would agree, Steph. And I think both you and I are very much not like, if I have this diagnosis, should I not do this exercise? Like, yeah, don't have those blanket rules. Everyone is a little bit different. General exercise, like you shouldn't be pushing into pain that is like intense, sharp pain.
For sure.
There's ways to modify exercises that you want to be doing while you build up the strength and work up to what you want to be doing when you're dealing with an injury. And
yeah, I work at a CrossFit gym. So if I told people not to do push-ups, I don't think I'd be work in there. They wouldn't like me too much. All right, do you want to do another question in there?
Yep. So can we talk about the connection between the rotator cuff and the bicep? When I do bicep curls, I get pain at the front of the shoulder.
So your bicep is not actually a rotator cuff muscle, but it very much functions like one, especially the long head of the bicep. It sits at the front of the shoulder. So oftentimes we will see bicep tendonitis or tendinopathy the same way that we see our rotator cuff tendonitis and tendinopathy. Again, it does have to do with our position, our posture, because it sits at the front. If you have poor posture and you're really dumping forward, it will get caught underneath there as you go into those overhead movements. Similarly to the push-up, if you're always dumping through it at the front, you can get irritation in that bicep. And it is very much similar spots. We can do some specific tests to determine bicep or rotator cuff, but you'll notice that the treatment is going to be very similar, whether it's your supraspinatus or the biceps long head. So it is all connected and it is all very much posturally related. Anything to add?
Nope, I think that was an excellent explanation. I'm just replying to a couple of these individual in the Q&A. So we're kind of double teaming this here. Mary wants to know, do you know of any like treatment that can be done for rotator cuff insufficiency? Like aside from everything we've talked about, is there any specific treatment? Like I wonder medically to.
Yeah, I think that would be a good one to consult with one of our physiatrists. Our physiatrists are doing some of the PRP therapies, which have been shown to help with tendon health. If you're not familiar with PRP, it's plasma-rich platelets injection. So they actually draw blood, they spin it in a centrifuge machine, which I think is in the back here somewhere. I'm in the doctor's office. And then they actually inject it back into your tendons. Now, this is something that the physiatrists are able to speak more to, or Dr. Wang Shu, who is also here at our clinic. But that is something that happens with degenerative tendons. That's something that we can talk about there. But I would refer you to the doctors to get a more complete answer.
Agreed. Okay. Okay, actually, I feel like we are making our way through this pretty good.
Yeah.
Yeah, I think we're on top. I've answered some in the Q&A.
Yeah. And if we don't get to them right now live, we can definitely, we're going to go through the questions and we can always send you guys an email because we have your emails from the sign up. So if we didn't get to it right now, we will definitely be in touch.
Yeah, for sure. Okay. Anyone else?
Anything really pressing
questions here. Really good.
All right.
Awesome. Okay, guys. So if you wrote exercises in the chat, we will email you. Remember, if you want us to call or email, please write call or email in the chat. This is your last sort of chance here before we close down the webinar. But thank you guys so much for attending. And I mean, on behalf of Steph and we really hope you guys were able to take some good information away and maybe just learn a little bit more about the shoulder and, you know, understand you're not the only one that's dealing with this. So common, and they do take time to get on top of. So stay diligent, and yeah, thank you guys so much for coming in to learn with us.
And here is our contact info at the bottom for Erin and I specifically, or also for our clinic if anyone did want to come in for an assessment and treatment, or you can always give us a call as well. Our number's up here. And we also are doing virtual treatments during this time to be COVID friendly as well, but we are open for business as well in clinic. Awesome.
Okay, excellent. Thank you guys so much for coming. I am going to save this chat now so I don't forget. And I think we're done. I'm gonna stop broadcasting if I can figure out how.
All right. Good night. Thank you for joining us, everyone. We appreciate it. And for being patient with me as I figured out these slides.
Like our spotlighting of my video. I guess 20 minutes to figure out. Anyways, thanks guys. Have a good night.
Night.